So we're going to start off with a land acknowledgement. Grand Erie Public Health is located on the traditional territory of the Neutral, Anishinaabeg, and Haudenosaunee people. It is now home to many First Nations, Inuit, and Métis community members, including the communities of Six Nations of the Grand River and Mississaugas of the Credit First Nations. This land is covered by the Dish with One Spoon Covenant, a peace agreement made between nations before settlers arrived. It characterizes our collective responsibility to each other and Mother Earth. We should take only what we need, leave enough for others, and keep the dish clean. We also acknowledge that these lands are covered by Treaty Number 3 and the Haldeman Tract Treaty, which mandate non-Indigenous settlers to share and collaborate with our local Indigenous communities. Just an acknowledgement. So Grand Erie Public Health was created from the merger of the former Brant County Health Unit and Haldeman Norfolk Health Unit. We deliver the same services, just under a different name now. Today we have a few presenters here with us. So I'm Jessica Pandy. I will be moderating the chat throughout the call. We have with us Richard Hirsch, one of our public health nurses, Haley Purchase, another public health nurse, Graham Ford, a public health nurse. He'll be watching the chat. And then Nicole Weir, one of our admin assistants, and Abby Davis, another admin assistant. So just a bit of housekeeping. I will also quickly throw these in the chat. But the webinar will go from 12 p.m. to 1 p.m. We will remain online until 1:30 p.m. So if you are able to stay afterwards, we will be available to answer further questions or further scenarios. All participants are muted. Questions are encouraged and can be submitted during the webinar in the chat or afterwards in the evaluation form, which we'll be sending out at the end of the webinar. A moderator and a nurse will monitor this chat and will answer any questions that can be addressed in the chat. We'll record all questions asked in the webinar in a document that'll be sent out afterwards when the recording is available. All questions asked in the chat and also in the evaluation form will be in this document. This webinar will be recorded. It's currently being recorded, and it will be available for review on the Grand Erie Public Health website, and an email will be sent to everyone attending when that recording is available. Here's a quick outline of what we'll go over today. We will be looking at the routine publicly funded immunization schedule, which was a document sent out to you in the original email, as well as the Ontario immunization catch-up schedules, out-of-province and out-of-country vaccine record assessment, vaccine ordering, and we'll have time for questions at the end. I will be passing the mic over to Haley Purchase.
Thank you, Jessica, and thank you to everyone who is attending our presentation today. We will review the publicly funded immunization schedules for Ontario. On this slide, you see a summarized schedule created by Grand Erie Public Health. You may have these schedules in your office as they were provided during our annual cold chain inspections. A list of vaccines required under the Immunization of School Pupils Act is included. These immunizations or a valid exemption is required for children attending school in Ontario. On this slide, you will see the publicly funded immunization schedules for Ontario, as well as a routine vaccine schedule summary. This is also provided during an annual inspection. These are great summaries to have on hand, as you can see the routine schedule clearly. It includes brand names, as well as some key tips on the back of the summary. You can also find this summary posted on our website. This is the routine schedule you will find on page 3 of the publicly funded immunization schedules for Ontario. This schedule begins when the child is 2 months old. Notice there are quite a lot of vaccines to be administered. However, we know that children have immature immune systems, and vaccines are an effective way to minimize the risks and illness and health complications related to these pathogens. A quick reminder regarding the MMR or measles, mumps, rubella vaccine expanded eligibility. Eligibility includes those who live, play, travel to, worship, or otherwise in the Grand Erie and Southwestern public health regions. Infants as young as 6 to 11 months old can receive a dose of the MMR. However, 2 doses of MMR are required after their first birthday. For children 4 years old, 2 doses can be administered with a minimum interval of 4 weeks between doses. If the dose is given too close together, it will be considered invalid. It is very important that we follow the minimal interval rules. Adults born in or after 1970 are eligible for a second dose of MMR. Now we will move on to reviewing the catch-up schedules as per the publicly funded immunization schedules for Ontario. The June 2022 version is the most up-to-date version available. Here we have some general principles of a catch-up schedule. Consider the individual to be unimmunized if they are unable to locate or confirm their vaccine history. If in doubt, vaccinate. Starting or continuing with immunization schedules is based on 3 factors: the individual's age, number of previous doses received, and risk factors. For under-immunized persons, continue the vaccine series. Restarting a vaccine series is not necessary. Be mindful of the minimum ages appropriate for vaccine products. An example of this is MMRV, or measles, mumps, rubella, and varicella. MMRV cannot be administered to children under 4 years old and over 12 years old. Please ensure you are following the minimum or recommended intervals between doses to avoid invalid vaccines. Routine serology is not usually recommended as the test is not accurate. When planning a catch-up schedule, use multiple injection sites rather than scheduling multiple appointments, as this will optimize protection. It is safe and effective. Use different limbs, or if using the same limb, use separate injection sites with 1 inch between sites. Determine interchangeability of products, as there are high and low dose vaccines. Some vaccines require less doses due to age and more mature immune systems that develop higher and longer lasting antibody protection. Other vaccines may not be required for older children and adults, as the risk of acquiring these diseases decreases due to immune function and epidemiology of disease. Delays between doses does not result in a reduction of final antibody concentration. As I previously mentioned, there are a minimum interval between doses, but not a maximum. Routine and catch-up schedule reminders. The capital letters for diphtheria and pertussis in DTaP IPV Hib indicate high antigen vaccine and is used to complete a primary series before the individual turns 7 years old. The lowercase letters for diphtheria and pertussis in Tdap IPV indicate low antigen vaccine. It is administered if the primary series is completed by 4 years old, or if the individual is 7 years of age or older. If it is not clear what vaccine was administered, or there's no proof of vaccine history, then administer the vaccine that is appropriate for the individual's age and vaccine history. Please note, if the 4th dose of Tdap IPV or DTaP IPV Hib was given after the 4th birthday with minimum intervals met, a 5th dose is not required. For polio, if the 3rd dose of polio is administered after the 4th birthday with minimum intervals met, no additional polio doses are required. Rick will provide more details and examples to interrupted vaccine schedules later in the presentation. On this slide, we have pneumococcal conjugate 15, MMR, varicella, Tdap, and the grade 7 immunization series. For pneumococcal C15, it is routinely administered at 2 months, 4 months, and 12 months old. If starting a catch-up schedule, please refer to Table 17 or page 11 on the publicly funded immunization schedule for the immunization series. Please note, the schedule refers to pneumococcal C13. However, the product has changed to pneumococcal C15 formula. For MMR, the first dose is routinely administered on or after the 1st birthday. Because MMR and varicella are live vaccines, it needs to be administered on the same day or 4 weeks apart. Please refer to Table 16 on the publicly funded schedule for interval requirements. For varicella, the first dose is routinely administered around 15 months old, and the recommended interval is 3 months between doses. For MMRV, or measles, mumps, rubella, and varicella, the dose is routinely administered on or after the 4th birthday and before the 13th birthday. For Tdap, which contains the low antigen, diphtheria, and pertussis, it is routinely administered between 14 and 16 years old, or 10 years after the 4 to 6 Tdap IPV booster. With grade 7 immunizations, if the vaccine series is started later in life, there are a few changes to the schedule. Routinely, hepatitis B vaccines are administered when children are in grade 7. The vaccine is an adult 1 milliliter dose formula. 2 doses are required and administered 6 months apart. If the individual has not started their series before their 16th birthday, then we would give a 3-dose of the pediatric 0.5 milliliter formula. The intervals are 0, 1 month, and then 5 months between doses. The hyperlink below is a Public Health Ontario reference guide for hepatitis B vaccine. It includes partial vaccine series schedules as well as travel vaccines such as Twinrex. The Mency ACYW 135 or meningitis vaccine is routinely administered when the child is in grade 7. The Mency ACYW 135 vaccine is publicly funded for individuals born in or after 1997. HPV or human papillomavirus vaccine series also changes depending on the individual's age. The difference with this series is if the vaccine was started before the individual turns 15, then the series is still 2 doses. If the vaccine schedule changes to a 3-dose series if the individual begins the vaccine series at 15 years of age and older. Please note, HPV and Hep B vaccine is no longer publicly funded or free once the individual has completed high school, unless they meet the high-risk eligibility criteria. Please note as well that Mency ACYW 135, Hep B, and HPV are considered a special order. These orders must be approved by a public health nurse at the health unit. Now Rick will present how to assess vaccine records and create plans for a catch-up schedule.
For the next section, we will be looking at some case scenarios of individuals who have fallen behind their vaccines and working through the process of assessing and developing a plan to get them caught up. For those of you who have a copy of the publicly funded schedule for Ontario, the blue and white document, we would like you to take this out now, as we will be referring to it through the next few slides. Specifically, we will be referring to the catch-up schedule on tables 1 to 3, found on pages 4 and 5, and also the vaccine interval and recommendation minimum tables 4 to 24, found on pages 9 to 13. When assessing and developing a catch-up plan, there are 3 important things to keep in mind. First, what is the age that they received their first dose? This would determine which catch-up schedule table to use. Schedule 1 is for children 1 to 6 years of age. Schedule 2 is for 7 to 17 years, and Schedule 3 is for 18 years of age and older. The rationale behind this is that as a child ages, the potential requirements to have less doses and also lower vaccine antigen concentration due to the ability to develop an increased immune response due to a more developed immune system of that child. Second thing you need to keep in mind is how many valid doses has the individual previously received. Tables 4 to 24 provide vaccine-specific information regarding the number of doses, recommendations, minimum intervals, and special rules for vaccinations. The third thing you need to keep in mind is the current age of the individual. This will be used to determine which vaccine products to give. Some vaccines are only licensed for certain ages. The current age columns are found in these table schedules. We will be working through some examples to show you the publicly funded immunization schedule as it applies to catch-up. For the 2 examples, we will be referring to schedule number 1, which is found on page 4 for children 1 to 6 years of age. In this case scenario, we have a 3.5-year-old who has received no doses of vaccine. So the age of the child receiving their first dose is today. In this case, for the first dose, we would look at the under 4-year-old column and plan to give the Tdap IPV vaccine, which is also known as Penticil. Also, measles, mumps, and rubella, Mency and pneumococcal 15. Even though it says pneumo 13 on the table, it is recognized that this has been replaced now by pneumo 15. The ministry is currently in the process of updating its immunization schedule, and we hope to have a newer version shortly. The second visit, 2 months later, we would look at the 2 to 3-year-old column and provide the Tdap, IPV, Hib, and varicella vaccine. On the third visit, 2 months later, we would look at the less than 7-year-old column and would administer the Tdap, IPV, Hib vaccine. Finally, the fourth column, the fourth visit, 6 months later, we now would look at the 4 to 8-year-old column, as they would have turned 4 years old at this point. At this visit, we would provide the Tdap, IPV, and MMRV. It is also worth noting again, as Haley mentioned earlier, that the MMRV vaccine is only licensed for children 4 to 12 years of age. Before and after this age, we would give the MMR and varicella vaccine separately, potentially at the same visit. This slide summarizes the plan we've previously discussed. We did want to highlight one point below, that normally MMRV would be given after the 4th birthday. But due to the increased measles activity in our community, current recommendations would be to give the second MMR earlier, for example, with the varicella at the second visit. For the next case example, we will also be referring to the vaccine interval tables. Table 4, which references the minimum interval and special rules for the Tdap, IPV, Hib, and Tdap, IPV vaccines, also known as Pediasil and Pentasil, for children under 7 years. We specifically wanted to highlight the following special rule outlined in red, stating the 5th dose is not required if the 4th dose was given after the age of 4, and there has been a minimum of 6 months between the 3rd and 4th dose. Again, the rationale for this is that as the child gets older, the number of doses required to complete the series and/or concentration of antigens may change since their immune system is more developed. The second slide, similar rationale to the first. In this case, we are looking at the polio table, table 13. This rule states if the 4th dose is not required if the 3rd dose was given after the age of 4 and there has been a minimum of 6 months between the 2nd and 3rd dose. With the final scenario, we have a 5-year-old child that has only received 2 doses of Tdap, IPV, Hib, the Pentasil vaccine. So for the first visit, they've actually had some visits already. So we looked at, they received their first dose of Pentasil at 2 years of age. So we are going to be using Schedule 1. It also notes in this scenario that the second dose of Pentasil was also given. It does not say when, but for the sake of this example, we are going to say that it occurred sometime between the age of 2 and 4. So now they are going to be presenting to us what would be their 3rd visit. The plan at this visit is to provide the Pentasil and also the MMRV and MenC vaccines, since MMR, varicella, and MenC have also not been given. We choose the MMRV since the child is between 4 to 12 years of age. The next visit, visit 4, would occur at least 6 months later, and we would provide the Tdap and MMRV to complete the series. Note, the Schedule 1 states Tdap IPV, but Tdap is only required. The reason for this is that the child has already met the requirements for polio, as we discussed previously in Table 13, since they received 3 doses of polio, and one of those doses, the last one, was after the 4th birthday, and at least 6 months after the 2nd dose. Nicole will now be reviewing the steps outlined for the province out-of-country records and some of the challenges when assessing and interpreting these records.
Hello, everyone. So for the next section of our presentation, we're going to be discussing out-of-country records, like Rick just said. We're going to start off with some general tips and challenges you might encounter with out-of-country records, along with some examples. And then after that, we're going to have a nurse come back in and go over some OPV/IPV guidance, vaccine equivalencies, and then finish with some practice cases. So we're going to start off with some general tips. The first step may seem obvious, but for some records can be very busy with information that isn't relevant to the immunizations that we're looking at, such as their weight. So you want to start with looking at the information that you need, which is the vaccine and the date given. Once you find the date, you need to make sure that you're reading it in the correct format. This can be day, month, year, month, day, year, or some even contain Roman numerals. If the format is not obvious, you might be able to find hints within the record. You can look at other dates on the record or reference the country of origin for clues. For example, the USA tends to use month, day, year format. Another important aspect is to look at the next appointment or due on column beside the given date column. Make sure that you're reading the given date of the vaccination. It can be helpful to cover up other columns to not confuse yourself. However, you can use the next appointment date or due on column if you're having trouble reading handwriting for hints as to what the date can be read as. And lastly, your most trustworthy source of information on a vaccine record is the stickers. The stickers should somewhat correspond to the agents that are printed on the record. For example, it might have PCV or pneumococcal written on the record, but there's a sticker for Prevnar 13. With the sticker, you can also use this as an indication of combined vaccine rather than having to list all of the agents separately. A similar evaluation can be made when written lot numbers are present on the record. So these are some next steps that you can reference if the record is proving to be a little bit more challenging. If you're still having some trouble with the record, whether that be a vaccine name you don't recognize, or you just want to look a bit more into the immunization schedule for a certain country, remember that you can use Google. But an important note with this is that most of the immunization schedules for other countries that you find online will be the current schedule and not historical schedules that may have been used when your client when it was immunized. However, that current schedule can give you something to work off of. Next, if you're having some trouble reading the record, you can use a camera and a translation app to help with the reading. Google Translate is a good option for this. And lastly, remember you have your client as a resource. They may be able to help with translations of agents or dates, or just give context for information that you see on the record. And here's just a summary slide of everything I just went through. You can use it as a sort of checklist when assessing a record to make sure that you're covering all of your bases. And now we're going to move on to some challenges that you might encounter when you're assessing a record. So different countries/regions may have similar names for different immunizations. A very common example of this is Penta. You'll often see this with records from India or Nigeria. Penta or pentavalent is an immunization that is coded as DPT, Hep B, and Hib. This could be confused with Pentacil, which is coded as DTaP, IPV, Hib. Though some of the agents are the same/similar, using one over the other can drastically change the outcome of a record assessment. If you're unsure, it's always best to double check. It may also be helpful to keep notes of common immunizations that you're encountering on foreign records. And this slide shows a good example of trusting the sticker over what is printed on a record. This can happen when there's a change in the immunization schedule after the record was printed. As you can see, the only components listed on the record are DPT and IPV/OPV. The sticker shows that they actually received Hexaxim, Off the top of your head, you might not know the components of Hexaxim, but a Google search will show that it contains DPT, Hep B, IPV, and Hib. And here's just a general example of a record that you might come across. The top box shows an example of a date that might be confusing. The number on the right looks like it could be a 2 or a 7, but context clues later in the record and the date of birth that isn't shown here verify that it is a 7. And this record also shows a due on and a given on column. It can be helpful to place something over the due on column so you don't accidentally use that date. But one last thing to note in the second picture shown here is the date in the given on column. It is only written in one cell when there are many vaccines listed for that age group. In most cases, it is safe to assume that all vaccinations were given unless there is a note on the record that indicates otherwise, such as a bracket or a stroke. And here's a good example of a record that is a little bit more difficult to read at first glance, but all we need to focus on initially is the type of vaccine column and the date of immunization column. So we can see on the left side of the box that all of the immunizations were given on August 20th, 2018, but this doesn't tell us the type of vaccine that was given. If we zoom out a little bit and look at neighboring columns, we can see batch number. One batch number is written for just IPV/OPV, and one is written across the rest. It is safe to assume that the immunization given was DPT, Hep B, and Hib, and the polio dose was given separately. We do not know if it was IPV or OPV unless we can find the lot number in an online database. If we cannot find this information, it should be coded as polio unspecified. Which brings us to our next section where Rick is going to be telling you guys some more information about international OPV and IPV administration.
So there have been some changes in the recommendations for oral polio vaccine. The OPV formulation used in other countries has changed. They are now using a bivalent polio instead of a trivalent. This was largely due to increased incidence of vaccine-related paralysis from serotype 2. The new formulation includes only serotype 1 and 3 and not serotype 2. So as per the Ministry of Health and Public Health Ontario, OPV given on or after April 1st, 2016 are now considered to be invalid. This includes all doses of OPV, unknown or unspecified polio vaccine, and IPV administered on the same day as OPV, due to the likelihood of fractional dosing. Note, some countries have updated their schedule to include this fractional dosing. So to summarize, consider it valid if OPV given before April 1st, 2016. If IPV is given on the same day as OPV in a combination vaccine. So an example would be tetanus, diphtheria, pertussis, IPV, Hib, Penticil vaccine. If IPV given alone on a different day than OPV, all of these would be considered valid doses. Consider invalid, and if invalid, the need to revaccinate the client. If OPV is given on or after April 2016, if the IPV is given individually on the same day as OPV, not in a combination vaccine, if polio vaccine type is unknown, IPV or OPV cannot be determined. All of these would be considered invalid, and there would be a need to revaccinate. Important notes: when revaccinating, utilize age-appropriate IPV series, IPV or combination vaccines as appropriate. When ordering vaccine from the health unit, IPV is considered a special order. Please use the special order form. Some additional challenges regarding vaccine equivalencies. Recognize that not all vaccines are equal. When assessing, we need to determine the equivalency based on vaccine antigen and concentration and comparison with the publicly funded schedule for Ontario. Caps indicate high dose and lowercase indicates lower dose. For example, out-of-country DPT, diphtheria, pertussis, tetanus vaccine, is a high dose. This compares to our Ontario diphtheria, tetanus, pertussis, IPV, Hib vaccine, Pediasel, which is a high dose as well. But Tdap, Adacil vaccine, is considered to be a low dose. Generally speaking, in regards to the routine publicly funded schedule, pneumococcal conjugate vaccines are considered to be equivalent, regardless of which pneumo 10, 13, 15 was administered. For meningococcal vaccine, it is important to identify the specific type covered to ensure it matches with the publicly funded schedule for Ontario. Measles, mumps, and rubella vaccines, some of these vaccines do not cover all these diseases. Ensure that they are covered according to the publicly funded schedule for Ontario. And finally, if there's any doubt or you can't find documentation of the vaccination record, assume it was not given and provide the vaccine. Next, Haley will be discussing some case examples of catch-up scenarios for our out-of-province, out-of-country clients.
Thank you. So how to assess out of province or country immunization records and plan for catch-up schedules. The same rules apply. Determine the age of the individual when they received their first dose. Then determine if the doses are valid, followed by confirming the current age of the individual. Here is an example of an out-of-province or country record. In this example, the individual is currently 6 years old. The first dose of diphtheria, pertussis, and tetanus is invalid as the child was less than 6 weeks or 42 days old. The OPV or oral polio vaccine is invalid. As previously mentioned, all oral polio vaccines administered on April 1st, 2016 and after are no longer considered valid doses. This child has not received a Tdap IPV vaccine between 4 and 6 years old, as well as no meningitis and no varicella. The following catch-up schedule, we would follow Schedule 1 on the publicly funded schedule. First visit would be a Tdap IPV, a Men-C, and a varicella. The second visit, which is 2 months later, would be an IPV and varicella. And the third visit, which would be 6 months after the second visit, we would give IPV. In this next example, the individual is 13 years old. You can see here that there is a limited number of vaccines on record. On this record, we see that a TD dose does not contain the pertussis, which is needed as part of a primary series. This individual also requires a grade 7 vaccines, Men-C, ACYW 135, HPV, and Hep B. The Hep B vaccine was started, however, more doses are needed to complete the series. There's also no record of varicella. The following catch-up schedule 2 would be our planned. So the first visit, we would give the Tdap IPV, a varicella, Men-C, ACYW 135, Hep B, and HPV. The second visit, which is 2 months later, would include Tdap IPV and varicella. And finally, the last visit, which is 6 months after the second visit, we would give Tdap IPV and HPV. Now Abby will discuss our vaccine ordering process.
Okay, so all vaccine orders must be placed using the vaccine order form. These order forms can be faxed or emailed. Please just note our updated email at geph.ca. In order to be processed for packing, offices must attach a copy of their fridge temperature log. This log must be current to the date the order is being submitted. Orders sent in without a temperature log are not considered complete and will not be processed until a valid temperature log is received. Please note it is best practice to have no more than 1 month's worth of vaccine inventory on hand. Whether healthcare providers order weekly, bi-weekly, or monthly, we ask that you adjust your ordering quantities accordingly. All orders are due weekly on Thursdays by 4:30 p.m. Pickup is the following Tuesday or Thursday. If orders include any special order vaccine requests, we ask that you submit as early as possible to give the VPD team time to approve these requests. An important reminder for cold chain reporting. It is crucial that you report excursions as soon as an out-of-range temperature is recorded. This is any temperatures below 2 degrees or above 8 degrees must be called in immediately to the health unit. The phone number is listed, 519-753-4937. Lastly, it is important to always submit a complete order form documenting an accurate inventory of all vaccines on hand, as well as the 4 weeks of temperature logs when requesting vaccines. In the event of a cold chain incident, having these records already on file will greatly speed up the investigation process, resulting in less disruption to your practice. And as always, if you have any questions, the vaccine ordering team can be reached Monday to Friday, 8:30 to 4:30 at the email previously provided, or we have a separate phone extension that is extension 452.
So lastly, we just like to provide some additional resources for you. So we've listed some helpful links and resources for international records, including vaccine schedules from other countries and different websites and apps to assist with translation. We've also included a link to the Ontario Public Immunization Schedule, the Canadian Immunization Guide, and our own website listing vaccine-related resources. Immunize Canada also has great resources geared towards both parents and healthcare providers that are very helpful. This finishes the formal part of the presentation. We would like to now turn it over to Jessica to open up the questions.
So if you would like to ask a question, you can do so by putting it in the chat, or you can raise your hand and we will unmute you if you'd prefer to ask your question verbally. So maybe we'll give about 2 minutes for the opportunity to ask questions or give comments. And if there are none, we do have some more practice scenarios that we could do for those who are able to stay on. Okay, so we have first question from Jessica. If starting the Hep B series after 16 and 2 have been given under the age of 18, do you give a pediatric dose for the third if the individual is now 18 or an adult dose? Would you like to take this question, Rick?
So just to recap that the child's over 16 years of age, they've had 2 doses of hepatitis B, and now they are looking to come in for a 3rd dose. So what you would do is you would give the age-appropriate vaccine. In this case, it would be a pediatric dose, 0.5 mils. Just also to clarify that because of the child's age, If they are still in high school at 18 years of age, it would be publicly funded. If they've left high school, it would not be publicly funded. But you could also look at, do they meet the high risk criteria for hepatitis B? They also may be able to receive it through the high risk criteria if applicable.
And just to answer to that next question, if somebody has received 2 Hep B vaccines, but their titers are showing non-immune, what would be the next step? I would ask you to refer to that Public Health Ontario document. It does go through those scenarios in those situations in terms of immunity.
Is there an update to the seasonal vaccine rollout regarding RSV, flu, and COVID vaccines? One of our team members is going to reach out to you and answer that. Okay, Aaron, we are getting University College forms requesting an adult Tdap. Patient may have just received Adacel at 14 to 16 and heading to post-secondary at 18. Is this a prescription? Does the health unit have a document to send to universities and colleges to educate them regarding this? Would like to do this.
Yeah. So it's as part of the publicly funded schedule that if they have not received a Tdap dose as an adult, they are eligible to receive 1 dose. Again, that's following the publicly funded immunization schedule.
Yeah, and this that dose is typically given 10 years after their previous dose. So typically 14 to 16 years of age, they will be receiving that vaccine. And then 10 years later is when they get that adult dose. Just recognize there are different requirements for universities. Some universities, especially universities in the US, have additional requirements that go outside of the publicly funded schedule. So just to be aware of that too as well when you're making that determination.
Oh, and it looks like Eric answered the other question from Dadewater Desney. And Abby did as well. Are there any other questions? You can throw them in the chat or you can raise your hand and we can unmute you. Aaron asked, there are 18-year-olds bringing in school forms stating they must have an adult Tdap, even though it has not been 10 years since the last dose.
Yeah. So yeah, it's still not like if they got the dose at 16, then no, we wouldn't give that. I'm not sure, maybe Aaron, if you can provide some background information as to what schools that you're seeing these forms saying that they have to get the 18-year-old booster dose, because again, it's not required. If they've received it between ages 14 and 16, they have that protection. So maybe, like I mentioned, if we could get some background information as to
Many schools.
Okay.
Oh boy.
Okay. Yeah, I mean, I guess we can try to look into that, but you know, unfortunately, we have to abide by that publicly funded schedule. So if it's an additional requirement for school, then it wouldn't be free. They would have to pay out of pocket for it.
Yeah, it looks like Eric said that the team will take this back and review that with the ministry. Okay, so if there are any more questions, we'll give about 30 more seconds and then we'll go through some additional practice scenarios. So the webinar is, we've gone through our content. So if you're able to stay on, we're happy to have you to do these additional practice scenarios. But if you're not able to, feel free to log off and you will be receiving an email when the recording is available. Okie doke. I think we'll move on to a few more additional scenarios. We'll end the recording here, but anybody who's able to stay on is welcome to do so.